Hello, and welcome to the Social Protection Podcast. I'm your host, Jo Sharp. According to the 2024 World Social Protection Report, 84% of the global population is covered by health social protection, that is, by law. In practice, only about 60% are effectively protected by a health protection scheme, and that falls to less than 20% in low-income countries. That leaves billions of people missing out, facing financial hardship or exclusion from essential healthcare services, and putting them at risk of poverty from catastrophic and out-of-pocket health spending. Social health protection is a fundamental component of broader social protection systems, working alongside other forms of social assistance and insurance to form comprehensive social protection floors. Today we'll be talking about Zambia, a country that has made recent progress in expanding its health coverage and putting that into the global context to explore what the social protection and health sectors can learn from each other towards the shared goal of universal coverage. We're celebrating the 50th episode of the Social Protection Podcast this month, and I'm delighted to have two guests to share it with. Herryman Moono is Director of Research, Planning and Strategy at the National Health Insurance Management Authority of Zambia, and Tessier is Health Protection Specialist at the International Labour Organization. Welcome, Herryman and Lou.
Thank you. Glad to be here on this podcast.
Thank you. Likewise. Very glad to be invited.
Lou, according to last year's World Social Protection Report, global coverage for healthcare or health protection is higher than other forms of social assistance. Does that suggest more countries tend to prioritise healthcare first? And why do you think it is that more countries have had more success in extending healthcare compared to other forms of social assistance?
One thing we can say is that trends when it comes to social health protection coverage actually tend to be closer to the trends in old age pension coverage. When it comes to social health protection specifically, which we define as concerning social protection programs that aim specifically at alleviating the costs of accessing healthcare services for people, we indeed can see that they are prioritized in many countries, and this is a combination of several factors. One factor is the recognition that health is an enabling right, so without it, people cannot study, work, or take meaningfully part in the community at their fullest. Therefore, the social demand is quite strong for healthcare services globally. It's also a risk that concerns almost everyone in the population. It's very difficult to anticipate. A correlated second factor, I would say, is that social health protection benefits are of immediate use to people. Contrary to, for example, old age or disability pensions, most people will need health services at some point within the year. And therefore, when the government launches a social health protection scheme, well, the benefits are visible immediately for people. Then many governments have found that social health protection is a key component and often the starting point for their national social protection system. And then I think thirdly, we can mention that there can also be more political factors. We can also see if we compare, for example, to social assistance program aimed at the poor or aimed at some categories of the population specifically, those can also face some reluctance from some streams of thoughts that believe that giving cash to people is dangerous or could create an incentive to work. And I think here with social health protection, because it's providing access to a service, we can more easily overcome that sometimes negative perception. And it's easier maybe to build a large political consensus at the country level. But at the same time, unfortunately, this is somewhat short-sighted in the sense that social assistance and social health protection are very much equally needed and synergetic in many aspects.
To that point, building that constituency, Herryman, Zambia's national health insurance scheme is relatively new, at least in its current form, implemented since 2019. Can I get you to start off by introducing us to that scheme, the NHIS? What were the gaps it was designed to address in Zambia? Who does it cover? And importantly, who pays for it?
Sure. So the National Health Insurance Scheme is a mandatory health insurance scheme introduced in 2019 created by an act of parliament that was passed in 2018 as a healthcare financing mechanism, but also as a vehicle to achieving universal health coverage by removing the financial barriers to accessing healthcare services in the country. It was noted for many years that out-of-pocket payments were really impoverishing many of our citizens, and we have high poverty levels in the country, with poverty levels as high as 60%, especially in the rural areas. And one of the drivers of poverty was really ill health induced, right? So with high levels of morbidity, you have high costs of accessing healthcare for those that can afford. But for many that cannot afford, you have increased mortality and continued morbidity. And of course, the cycle of poverty continues. So the government saw it fit that it needed to create a vehicle, a mechanism that would pool resources together and alleviate or eliminate completely the out-of-pocket payments that many of our citizens were exposed to, and therefore drive progress towards universal health coverage. The country, using the tax revenue financing mechanism, was not raising enough resources to fully fund the healthcare system, and had to rely to a large extent on out-of-pocket payments for those that could afford, and ultimately leave many others out of accessing quality healthcare services. So to raise additional revenue for the healthcare system, but importantly, to eliminate completely out-of-pocket payments at the point of accessing healthcare for the entire segment of the population. Related to that is to ensure really cross-subsidization and risk sharing between those that are able to contribute and those that are unable to contribute, the healthy subsidizing the sick and the rich subsidizing the poor. So in terms of the mechanism, it is a contributory scheme, and contributions are based on one's ability to pay, but access to healthcare services is based on one's need. So regardless of how much one may have contributed, they will access the services they need without any risk related to their contributions. So really, it's a social health protection scheme in its purest form, ensuring that there is solidarity and risk sharing in access to services. Now, the people that contribute, ideally, it's everyone. But as you would imagine, it being a contributory scheme, most of the contributions come from those that are formally employed, both private and public sector. And contributions come in the form of payroll-based deductions. So the workers and the employers are critical factors in the management and operations of the scheme. For the informal sector, contributions are based on what we call a declared income. So we have an income assessment tool where people are assessed based on their income. A contributory base is determined. Then you have the wider segment of the population, the poor and vulnerable, that have no contributory capacity. The NHI Act is very clear that it is the role of the state to support those that are unable to pay onto the scheme, but enable them to access healthcare services like everybody else, ensuring social solidarity and no discrimination in access.
As Lou also touched on, that interrelation between poverty and ill health, and that importance of addressing one in order to affect the other. Lou, on this podcast, we are actually more often talking about the social assistance side of social protection, tax finance, transfers. How is insurance different? How are insurance mechanisms different to that kind of more traditional form of social assistance?
All right, because we are talking about social health protection, I just want to warrant that actually this is the one field, the one type of benefits in the social protection system where the line between insurance and assistance is also the hardest to draw. In theory, social health insurance designates social health protection schemes that are at least partially contributory, therefore collecting contributions from workers, employers, and sometimes matching contributions from the government. While in theory this definition may seem crystal clear, what countries have called social health insurance schemes actually varies widely. So many countries do collect social security contributions that they earmark for health, but it really isn't a determinant of how the system works to protect people against healthcare costs. Because, for example, you can see that in many Latin American countries, we can see Mexico, Peru, Argentina, those resources are not pooled further than the pool of contributors. And then you can have some parallel public and private systems that exist. At the same time, in many Asian countries, for example, if we look at Indonesia, Vietnam, the Philippines, we see that those countries have built national health insurance systems that actually pool social security contributions with additional resources. and are universalistic in their legal scope. So already when they created the system, that it was to cover everyone. So I think that what we can also see is that some countries have introduced social health insurance with the idea of allocating additional resources to the access of healthcare services. But in other contexts, social health insurance has been introduced to actually reduce the healthcare budget by making people contribute instead. So this is what's particularly interesting, is that we're showing that it's also possible to build a comprehensive protection using a combination of arrangements. And what we're also seeing is that there are crucial advantages in having a national scheme that includes everybody, meaning that you have the broadest risk pool and purchases health services in a way that guarantees the best value for money for the community. Now, there is a strong advantage of dividing this function from the healthcare provision function, particularly if your health system is pluralistic and you wish to include private providers. And this is often necessary in many countries where the private health sector is wide, but it also comes with higher financial risks. And so I think this is interesting that we have Herryman with us today, because Zambia is part of those countries that, from the legal framework conception, has already developed a universalistic vision. I think this is an element that can be also an inspiration, for example, for a lot of old age pension systems where the social assistance pension tend to be very strictly separated from the contributory ones.
To this point of universality and being able to reach more people, Herryman, extending health protection to particularly informal workers, vulnerable people, is a challenge that many countries are grappling with. And as we know from the World Social Protection Report, in fact, it's one thing for people to be eligible by law, to pass the laws and put the systems in place, but it's another to actually deliver on the promise of access, because there are a lot of challenges in between there. So what progress has Zambia made to reach and include people who weren't previously covered, and what were some of the challenges that you've had to overcome?
Before the introduction of the mandatory national health insurance scheme, only 4% of the population had any form of health insurance coverage. So the 96% had to rely on either out-of-pocket payments or any other mechanism to access healthcare services. And really, that's where the biggest challenge was, and hence the intervention to ensure that the coverage is enhanced. So in the last 5 years, we have moved from 4% to 25%, reflecting coverage of the formally employed. We stand at about 15% of the population, and then 10% in the informal sector. The biggest challenge remains the informal sector. How do you ensure that, one, we capture them, two, they are compliant with their contributions, and then three, of course, we have had challenges with the few that have been captured because of low wages, low incomes. When you look at the utilization, it poses this an insolvency risk. And thirdly, for us, is how do you extend coverage to the poor and vulnerable who need healthcare services the most? And as I mentioned earlier, 60% of the Zambian population is poor. Among the 60%, 40% are extremely poor. It's the 60% that have no contributory capacity. And that's where state financing comes in. But with fiscal constraints, it becomes really difficult because the government has to juggle multiple priorities. So that is where now we have partnered with ILO and done a lot of work to appreciate what would it cost to extend coverage to the non-contributing segment of the population. What are the feasible sources of financing that could be looked at to generate resources that are required to subsidize the poor and vulnerable? And then for the informal sector, of course, is devising mechanisms that make it easy for them to register, make it easy for them to make contributions, but importantly, that they see the value. With the informal sector, because you're paying out of your pocket, that contribution, the issue of value, the immediate value has to be demonstrated. And that's where investment in service provision comes in. But also related to that is just the issues around social marketing and relying on other social protection mechanisms such as pensions, houses, and old pension support that the informal sector members receive. So instead of us going in as a scheme to begin to register and sensitize people on the importance of registration, we begin to work with the Pensions Authority and the Workers' Compensation Fund Authority to go in with one social security product that has pension, that has health, and that also covers workplace injury. That way you create convenience in registration, convenience in payment, and enhance compliance in making the contributions.
Lou, what are some of the other policies or programs governments put in place to extend access to healthcare?
Well, I think it's an important question. And I think before I go into the range of social health protection programs that can be used, the mechanisms that can be used, I think it's also very important to first acknowledge that social health protection is only one of the many policies that are needed for people to effectively have access to healthcare services without hardship. We need to see that social health protection policies can only work if health services of quality are available. And it seems like a small thing, but it's actually a big thing. So it also means that we shouldn't be seeing social health protection as something substitutive, but that's something that is really complementary to an adequate offer of healthcare services, which also encompasses the decent working conditions of health and care staff. So I think when it comes to social health protection mechanisms themselves, we're seeing a range of universal approaches. There you have national health services where public facilities offer free service at the point of care, entirely financed by taxes by the Ministry of Health itself. It's the case in Malaysia or Brunei, for example, in Asia. You have the national health insurance mechanisms that combine contributory and non-contributory entry points for different categories of the populations. You have this, for example, in Indonesia, in Turkey, in Costa Rica, in Vietnam, in the Philippines. If we look at those middle-income countries that have attained high percentage of coverage of the population, near universal. We can also see that sometimes this is not achieved through one single scheme, but several, like in Thailand, that has achieved universal health coverage early on. In a smaller number of countries, you have mandatory private health insurance for the entire resident population, with some subsidies for vulnerable populations. To my knowledge, this has only been really successful in Switzerland and the Netherlands, and this also comes at high cost for the public sector at the end of the day. And then you have categorical and targeted approaches. So usually, those ones then really look at specific population groups. You have user fees or waivers or exemption for specific categories of the population. So, for example, what we see is that in India, you have the Modi scheme that is actually covering specifically people below the poverty line. You also have countries such as Niger, and I would say a number of West African countries that have introduced user fee waivers for pregnant women and children under 5. This is also a way to somehow align scarce resources to a very strong need. We can also see user fee waivers or vouchers for specific health interventions. So, for example, in Kenya, Madagascar, and many other countries, those mechanisms were put in place for maternal and child health interventions, for tuberculosis, for malaria, or for HIV. And then the reality is that in practice, most countries have adopted some kind of a mix of all of those mechanisms that I've listed. So what is the most important, I think, as a lesson is to have as a clear objective reaching universal coverage, to have it anchored in the law, and to create entry point in your system for those who are in the informal economy on the one hand, and for populations who are poor or vulnerable and cannot contribute on the other hand.
Herryman, increasing access to health insurance means increasing demands on health service providers, medical supplies and so on, if more people are actually able to access those or afford those. And as Lou just touched on, they do need to be of sufficient quality in order to actually deliver the healthcare that's needed. How has Zambia addressed that challenge of meeting those increased needs or that increased demand?
Indeed, with increased enrollment onto the National Health Insurance Scheme came increased demand for healthcare services, but not just the demand for ordinary care, higher quality of care, because people now are entitled to access services that they're paying for through the contributions that they make. But also, on one hand, what that also does is that the contributions make available resources for investment in enhancing the quality of care, especially in the public health system. Certainly what we saw was once the scheme was widely appreciated, we saw a spike in demand and utilization of healthcare services. For us, that indicated that there was a huge unmet need in access to healthcare services. But also what that did was that it really shook the healthcare system, because suddenly they have to respond to the surge in demand in healthcare services by the population. And that put a strain on a number of things. One, what we saw was that the healthcare system was not optimal in responding to the availability of drugs, because the people that it was servicing were limited. Secondly, we faced a number of challenges in diagnostic services. So you have the drugs and diagnostic services, which when you think about, expose people to the most costs if they're paying out of pocket. But what the scheme also allowed, therefore, is to provide financing, which was one of the key drivers for its creation, that you provide financing for the healthcare system to be able to effectively respond to the needs of the population. So with increased demand and utilization comes increased financing to invest in the healthcare system. So that was an opportunity for us as a country to reinvest in the healthcare system using the contributions that the people have now started making in addition to the general tax budget. Well, I can say that luckily, like many other countries, the health budget financed by the tax system has actually been increasing alongside the creation of the scheme. So we did not see a shift by the government to reduce the allocation in the health sector because now we have a national health insurance scheme. But most of the funds were now being channeled to increasing the capacity of facilities to provide quality health care for the population. And that way you respond to the quality aspect and you have higher levels of satisfaction among the members that are contributing. But importantly, you ensure that the services respond effectively to the needs of the population, thereby enhancing progress towards universal health coverage.
Lou, as we've touched on a few times now, social protection, of course, can have a major impact on health and well-being as well. So how does providing a social protection floor for all and everything that entails also promote health outcomes?
I think just a little bit of framing to this would be to say, we know that human health and well-being are strongly determined by the conditions in which people live, work, grow, and age, which has been the premises of the work of Dr. Michael Marmot and the Commission on the Social Determinants of Health of the World Health Organization. And they have gathered the evidence and showed that poverty, social exclusion, and inequality negatively impact on health, including mental health, because they affect nutrition, education, housing, healthcare-seeking behavior, and other social determinants of health. And so, as we see, those determinants, they're rooted in the unequal distribution of power and resources, which generates a social gradient in health at the local, national, and international levels. And they result in inequities in health outcomes within and between countries. Because social protection policies directly tackle poverty, inequality, and access to essential services, and they do this in a comprehensive manner through social protection floors, or at least at the ILO, this is what we hope they should aim to do. They play a critical role in promoting well-being and resilience and contributing to a broader shift towards an economy that promotes human well-being and all of it within planetary boundaries. So what we see is that the evidence is a bit fragmented, but you do have many studies that show the impact on health of social protection programs. What we're also seeing is that the systematic differences in risk and exposure to income security and the lack of inadequacy of social protection has been identified as a main factor that people perceive explain their differences in health and well-being.
Herryman, Zambia has other social protection schemes. You mentioned a few earlier, but those include the social cash transfer for the most vulnerable households, pensions. I understand there are also initiatives and registration of people with disability and so on. How do these intersect and coordinate with the National Health Insurance Scheme?
Indeed. So the National Health Insurance Scheme, the Act was really comprehensive. in nature, ensuring that we meet the ILO principles around universality. And in the framing of the Act, in the law, we were very clear that there will be segments of the population definitely that will have low capacity or no capacity at all to contribute, since our scheme is a contributory scheme in nature. And therefore, the Act provided that people that are deemed poor and vulnerable, and these are people mostly under the social cash transfer program, the social assistance program run by a separate ministry, the Ministry of Community Development and Social Services, will be exempt from making contributions. The state will contribute on their behalf instead. Persons with disability as well will be exempt from making contributions, and the state will make contributions on their behalf. So that means that we have to have close collaboration between the health insurance scheme and the social assistance scheme to ensure that, one, we identify the people that are supposed to be exempt because they're the most vulnerable, and ensure that they are immediately linked to the National Health Insurance Scheme to access healthcare services. But also, when you look at these people that are exempt, they are also the ones in most need of healthcare services. So on one hand, they need healthcare services the most. And the inclusion criteria, for example, the social cash transfer, you're looking at actually households with an individual who is terminally ill, for example. If you're looking at households that are female-headed with children below the age of 19, including babies, you're looking at the elderly. These actually need healthcare services the most. But then the ones who are likely to be left out because they have no capacity to contribute. So we had to take care of them in the law to ensure that we are as inclusive as possible. So there's very strong collaboration between the health insurance scheme and the social assistance scheme to ensure that, one, we share data around the individuals that have been identified as needing enrollment onto the scheme without any contribution. But importantly, that in our data sharing, we also share experiences around the targeting. We have left out other people that actually have been captured. So data sharing is critical in the implementation of the scheme. We rely on data and the registers that are managed under the social assistance program of the Ministry of Community Development and Social Services. So there is a very close link and data sharing protocols that we've put in place to ensure that as and when the people that qualify for enrollment as exempt categories are registered, that information is transferred to us and they are registered onto the scheme. But also it helps us to begin to run projections on what the feasible liabilities would be in the future.
Lou, finally, I'd just be interested to hear from you. Where else do you see the synergies or interactions between health and other forms of social protection? How can social protection support universal health coverage and vice versa? And what could they be learning from each other?
This is a very vast question, but let me try and go through a few elements that I think already Herryman has given us quite a few illustrations of how that can be done. First, we need to all then come back to the premises that life contingencies are not experienced in silos at the individual and household level, right? So it's not a siloed response that is needed, but a comprehensive set of benefits for people. And this is really what has been, I think, quite strong in the universal social protection concept, the way it's been developed since 2021, which was the last general discussion on social protection at the International Labour Conference, is that really this comprehensiveness is a core element of what a universal social protection system should look like in the service of the various needs of households. So there are three key points of, I would say, possible joint work or enhanced joint work. One is coordination at the policy level, advocating for rights-based entitlements across that are comprehensive in nature. And here, I think it's good to make the link with the current ratification campaign that we have for our Convention 102, which is the minimum standard convention on social security and which aims at establishing already a response to 9 identified contingencies across the life cycle and establish systems that do respond to those 9 contingencies. So we can already see here that the comprehensiveness is at its core, and we have set for ourselves a target of 60 ratifications, and we're hopeful that this is going to happen. And this also provides the image that, this is gaining interest at the country level of having those coordinated systems that have a legal basis. And I think in this respect, somehow, the COVID-19 crisis and pandemic has been instrumental in showing that this is a must and not a nice to have. The second point is advocacy and a joint agenda for resource mobilization. Health and social policies are too often opposed in discussions with Ministry of Finance. They are put in competition. And we need to change this paradigm here to face the challenges of today and tomorrow. When we see the huge challenges that are coming with a changing climate and the climate crisis, I think all the social and health inequities, it will reinforce that it's not a trade-off between the two, but it's actually synergetic, and you can achieve positive outcome and human development by having both, and to reinforce then synergies thereof at the national level and within budget allocation. And then we see a third point, which is the day-to-day synergies at the operational level. I think that Herryman has given a very strong example, but clearly when it comes to identification, awareness raising, referrals, joint procedures, joint monitoring and evidence generation, impact evaluation between social insurance and social assistance, cash benefit programs, and social health protection policies, I think this is really where we can see that indeed there is no trade-off, but also it can facilitate everyday operation. Within social protection systems, we see that where countries have built strong social assistance programs and frameworks with social registries, those tools they can share with social health protection programs so that those people immediately also get a health cover. We can also see that there can be referral mechanisms put in place. So in countries with very strong primary healthcare systems, the primary healthcare provider can also provide information and referral to social programs, to social care, social welfare, social protection, and social assistance programs. But if silos are very strong, impulsed from the policy level, it's very difficult for the operational level to synergize. So I think this is where we see the potential next steps.
Herryman, Moono and Tessier, thank you so much for joining me on the Social Protection Podcast today.
Thank you so much for inviting me. Great to have this discussion with you.
Likewise, thank you very much. And I'm so glad that the socialprotection.org platform has decided to put the spotlight on this topic. I think this is very timely. Thanks again.
Before we go, we like to end each episode with some quick wins. We ask our guest to bring in some recommendations for research, news or events that have sparked their interest and that we think you, the listener, should know more about. Joining us for Quick Wins today is Peter Ombasa. Peter is Social Protection Specialist and Assistant Director for Children's Services for the Government of Kenya. Welcome, Peter, to the podcast.
Thank you so much.
So today I wanted to ask you a little bit about the USP 2030 joint statement titled Key Messages on Social Protection for the World Social Summit in 2025. That's a UN-sponsored event that's coming up in November this year that's focused on addressing social development and looking to provide new momentum towards the Sustainable Development Goals and the 2030 Agenda. Peter, can I start by asking you about your role in the joint statement and what you hoped it would achieve?
Kenya is a developing country, and social protection is not very expanded in terms of coverage. So together with our friends in ILO, WFP, UNICEF, and the others, we started the process of seeing how can we expand social protection to reach the unreached in society. What was the pool? What is our financing? What is our reach? What are our interventions in terms of non-contributory schemes? Where are we in terms of contributory? All these are things that we were asking ourselves in the back of our mind as government. How can we make social protection reachable to the unreached in society? And that is how we found ourselves rightfully inside the USB 2030 to advocate for universal social protection by the year 2030.
So, in the joint statement itself, I was interested to see the advocacy right up front. The statement urges governments to accelerate progress towards universal social protection by annually increasing the share of population covered for at least one life cycle risk by at least 2 percentage points per year. Can you tell me a little bit about this target, and particularly from your position within government in Kenya, whether you think that's a useful target or an achievable target?
There's no target that cannot be achieved as long as there's a willingness to achieve. That's one thing. Where are we as a Republic of Kenya in terms of advocating the advancement of social protection, especially the increase in financing for social protection? Very critical thing that we always look at. In Kenya, the number of coverage is fairly small, but are we doing something towards it? The answer is yes. And in Kenya, we have different dimensions and strategies to reach the unreached. Among them, how do we have an influence on the political atmosphere to make social protection really a target for the politics? A case in mind is when we did what we call the third social protection conference in Kenya, whereby the president himself said, for us to move the agenda of social protection, we need to increase the numbers from what we had earlier on of 1.2 million to now what we are adding to 2.5 million. That's a tremendous progress. In terms of funding, we have moved from 38 billion and we are looking at 60 billion Kenya shillings. That is the best that we have ever done in Kenya in terms of social protection expansion and, of course, coverage. We might not have reached the 2 percentage points in any particular year, but are we progressing in the right direction? I think we are.
The joint statement talks about financing in a couple of different ways. And as you're very clearly pointing out, you need to increase financing in order to increase coverage. So I'd just be interested if you have any further thoughts on how to really expand that financing that's so important.
Number one is reallocating public expenditures so that we are able to effectively and more consciously allocate a certain percentages of our GDP towards social protection. Why? Because that is the only way we can reach everybody who is in need in society, and therefore create confidence amongst the population and also build trust amongst those who pay taxes. The third is expand social security coverage, either by looking at how much they are paying, who is covered, how is covered, what has been collected from the public, so that people create trust in those organizations or those particular institutions that are put in place by government to be able to serve them. The third is lobbying for aid, most especially in the global south. Occasionally, we depend on grants and sometimes on credits. That's why we invest more in our systems, so that our systems are more robust, more enticing, more transparent, more accountable, so that whoever puts on his dollar or a shilling or a franc is sure to get the return on investment. Lastly, Africa and Kenya is having a lot of debts. That one is there for sure. How do we work around the debts? Can we restructure these debts? If we restructure debts, can we have some kind of privilege whereby if a debt was for 10 years, taken to 50 years, so that we breathe a bit, the available funds that we could have paid for debts can be available to expand social protection in the meantime.
And as we're also coming up to the 4th International Conference on Financing for Development, which begins at the end of June, on this podcast, we're planning to dive deeper into the topic of financing for social protection in our next episode. So that's a great lead-in, a great introduction to that next episode, and listeners can stay tuned for that. Peter, on the subject of USP 2030 or development financing more broadly, are there any recent papers or analysis that you would recommend listeners check out?
The most recent that I've liked is the one that was done by Cataneo. Very interesting document, though it was also counter-reacted by a gentleman called Dr. Stephen Kidd. Those papers are very critical for anybody who wants to understand what social protection is all about. What are the financing gaps that we are looking about? That paper is just marvelous to me. It ignites some kind of thoughts that, okay, where are we? If in Africa will take another 50 years to get social protection, then 50 years, some of us will not be around. What can we do now? It's a paper that provokes thoughts.
Yeah, thanks, Peter. The first of those papers by Cataneo et al. Estimates the financing gap for achieving universal coverage of the 5 types of social assistance in low-income countries at 19.8% of GDP, obviously very high, while the KID paper disputes those figures and offers a much lower estimate. We'll link to both of those papers in the episode description. And I just wanted to mention for our listeners an episode of another podcast, ODI's Think Change podcast. The most recent episode was on how can development financing be reformed, the road to Severe. For listeners interested in this topic, I recommend that one. Thank you very much, Peter Ombasa, for joining me on the Social Protection Podcast today.
Much appreciated.
And thank you for listening to this episode of the Social Protection Podcast. As I mentioned at the top of the show, this episode is appearing in your feed as number 50. With our various special series and bonus episodes, it has actually been more than that, but we felt it was an important milestone to mark. Thank you to all of our guests and our listeners for your support so that we can keep bringing you this show. You can find all of our 50-plus episodes on the socialprotection.org website and on your favourite podcast platforms. Be sure to like, subscribe and leave a review. Back next month. See you then.